So today, in part two of our discussion on how to approach chronic dyspnea, we'll be discussing how the auscultation of the pulmonary of the lungs, of the pulmonary system. So before we get into the weeds of it, I want to discuss a point that was not clearly identified or highlighted in the last video. That is cardiac causes of shortness of breath. Now, I did technically discuss this in the last video. In that alveolar processes, one of the processes that affect the alveoli is fluid accumulation, which is pulmonary edema, and one cause of pulmonary edema is cardiac pathology. So, cardiac causes of shortness of breath cause shortness of breath via the development of pulmonary edema. So technically pulmonary edema is a alveolar process. That is why the diagnostic framework, the anatomical framework I uh, used the pulmonary anatomy as the framework around which we developed our differential diagnosis. Now, as you can see in this diagram, clearly the this is a diagram that enumerates all of the causes of pulmonary edema, and we'll be discussing it in detail in our discussion on pulmonary edema. But as you can see, the elevation in left atrial pressure, either primarily due to mitral regurgitation or mitral stenosis, or something occupying the volume of the left atrium, such as an atrial mass or thrombus, uh, or secondarily due to back pressure from the left ventricle because of any of these cardiac causes, such as an abnormality in left ventricular dilatation, such as heart failure with preserved ejection fraction, any type of tachycardiomyopathy or bradycardiomyopathy, or fibrosis within the wall of the ventricle or outside of the ventricle, such as in chronic constrictive pericarditis. All of that would cause back pressure into the left atrium, and the left atrium being in direct contact or direct continuation with the pulmonary veins, which are in turn in continuation with the pulmonary capillary bed, would result in increased hydrostatic pressure within the capillary bed. Basically, although there are cardiac pathologies that cause shortness of breath, cardiac pathologies cause shortness of breath by causing pulmonary edema. So that is why specific attention was not given to this, because there will be a dedicated video on pulmonary edema. Okay. Now, having gone through that, we'll be now progressing to our discussion on the examination of the respiratory tract. Now, I like to keep the examination very efficient. I don't like to have a lot of redundancy in the examination process. So what I'll be discussing is what is relevant. A lot of medical teaching discusses physical examination, and that is there is it starts with inspection, and there's palpation, and there's percussion, and then there's auscultation. Then in some cases there are special maneuvers. So see, a lot of this, there's a lot of redundancy in those steps. So a lot of what you see in inspection, you confirm on palpation. Okay. So why waste so much time doing this? Okay. And often a lot of it is non-contributory, you get nothing out of it. Okay. Then a lot of what you palpate, you confirm on percussion. Okay. And then similarly with auscultation, you confirm with auscultation. So see, I don't want to keep repeating myself, don't want to keep doing this. As such, when you do it clinically, you don't follow this strict paradigm. You essentially want something efficient that gives you the most amount of information and most usable information that you can get. Okay. It is by no means going to be I'm not going to tide over or remove the complexity involved in pulmonary examination, but I will not be discussing the redundant parts of pulmonary examination. So you can any medical school in the world will teach you all of that. I want to concentrate on what is relevant and what needs interpretation. Okay, so we'll start with tracheal / mediastinal shift. It's a relatively easy concept to understand. If there is a loss of volume on one side, here I've shown a collapse of the right upper lobe, that causes the trachea to shift towards the side of the loss of volume. And if there is an increase on volume on one side, such as pleural effusion on one side, that causes the trachea to shift to the other side. Now, importantly, if there is a collapse along with, say, a pleural effusion on one side, the trachea will not shift in either direction, because one process is pulling the trachea, the other process is pushing the trachea, so they nullify each other, and often the trachea is in the center. Okay, but the first step is always to decide where the trachea is in relation to the midline. Okay, now the second step is to decide where the apex beat is, because that is a marker of the outermost and lowermost portion of the precordium. That is what is the definition of an apex beat. So that tells you where the lower end of the mediastinum is at. Okay, so similarly it will shift it away from something that increases pressure on one side of the chest cavity, and it will shift towards areas of loss of volume, so a collapse or a fibrotic process. Okay, so this is relatively easy to understand, nothing much to it, so we'll go on to the next. So see, once you have once you have palpated the trachea and you know whether it is shifted to the right or the left, all you need to do next is just percuss the side to which away from which the trachea is shifted. You percuss there. If you get stony dullness, that means there's a fluid accumulation on the contralateral side. Say if there is tracheal shift to the right side, you percuss on the left side, you get stony dullness, it's fluid on that side. Okay, so that's about it. More than that, don't go into the details of whether there is some dullness. That is very subjective and doesn't add anything to the actual examination. Now, what does add to the interpretation of the examination is auscultation of the lungs on both sides. Okay, so we'll be discussing the principles behind it and how to interpret it. Okay, now see, sounds in real world settings are actually compound sounds. Okay, so what does that mean? That means that sounds actually consist of multiple small multiple waves that have interfered with each other, either constructively or have interfered each other in a destructive manner, in order to produce a complex sound that is heard by your ears. Okay, so this is actually a diagram I've taken from a discussion on Fourier analysis, which is something we'll come to when we discuss MRI physics later on in our journey together. However, as you can see, there is a complex wave here. Okay, this complex wave can be deconstructed into multiple simpler waves, sines and cosines. Okay, with varying amplitudes. And actually, in Fourier analysis, what we do is we represent them along a frequency axis. We'll come to that later. But see, any sound that you hear in the real world is actually a combination of multiple individual frequencies. Okay, now the thing is that sometimes when sounds are deconstructed into multiple wavelets, in Fourier analysis, essentially you can use an infinite number of frequencies to do so. Okay, but the range of human hearing is only restricted within around 20 to 20,000 hertz. So we don't really have that range of frequency to deconstruct any random sound that we hear. Okay, so if there are sounds that don't follow a very reasonable pattern, as in they show rapid fluctuations in the amplitude and sudden changes in frequency within the components of the sound, that is perceived by the human brain as something that is not pleasurable. Okay, something that creates a little bit of disturbance. So those sounds are then called non-musical sounds. Now, in classical physics, particularly anybody who's done medicine in India would have learned this in 11th and 12th. You would have heard about musical sounds. You would have learned in detail about musical sounds. So here I've given an example of the musical sound that is produced when a guitar string is strung. So see, there are multiple frequencies that are possible, which are basically integer multiples of each other. Okay. Now the lowest frequency at which the guitar string can move, to a maximum amplitude back to its midline position, and then back to the maximum amplitude and then back, that is produce a periodic function. That frequency is what we call the fundamental frequency. Okay. But because this is a standing wave, that is a wave of a particular frequency is going in one direction and then coming back in the same direction, so two waves of the same frequency and amplitude are interfering with each other. They undergo multiple positive interferences and produce higher frequencies, what are known as overtones. So you can have a first order, second order, third order, fourth order, fifth order overtone. So musical sounds tend to produce these kinds of overtones if they are interfering with one another and they are of the same frequency and amplitude. So this is something that we'll see. So a compound sound could be made up of multiple such pure frequencies that have undergone positive interference with each other and have produced overtones. Now this kind of a compound sound is somewhat of a musical, or a it sounds nice to the human ear. Okay. Whereas there also could be a very randomly, haphazardly arranged combination of frequencies and amplitudes. Okay. And that would produce a very tasteful sound. Okay. What that is then subjectively called non-musical. Okay. So as we go ahead, you'll understand why this is relevant. Okay. Now, when you'll take your stethoscope and you put the diaphragm on the chest wall. What is it that is producing the sound? Okay. So initially you ask the patient to just breathe in normally and breathe out normally. Okay. So what is producing the sound? There are three mechanisms of production of sound. One is turbulent flow. So as the in a non-ideal fluid, that is a fluid that has got internal friction, okay, experiences inertia. So in such a fluid and has got a certain viscosity and density, okay, and is compressible, importantly. Okay, such a fluid, when it is suddenly made to speed up, or when there is a change in its velocity, okay, the normal laminar flow of the fluid can get disrupted and the fluid enters into what is called a turbulent state. Okay. So as you can see, the vectors of movement of the individual particles within the fluid are quite haphazard and going in different directions. Okay. So this results in some parts accelerating, some parts decelerating, okay, producing mechanical waves which then dissipate out, producing sound. Okay. So importantly, this kind of sound would be very random, would be very haphazard, unless there was one or two elements within this particular setup that were vibrating at a relatively constant frequency and amplitude. So usually this produces a non-musical sound. However, in some situations, we will discuss this even in cardiac auscultation of mitral valve prolapse auscultation. In most situations, this produces non-musical sound. Sometimes it can produce a musical sound. Now, the second situation in which this sound can be produced is when you have a open airway pipe, essentially, okay, and a standing wave forms inside that. So this typically happens in the airway within the second to the seventh generation of division of bronchi, and this produces a relatively musical sound. We'll discuss that again later in detail. Okay, so what are called bronchi. Okay, and on wheezes. Okay, then now what can happen is, in a pathological airway, mucus or any foreign material or even some tissue can block the airway. Okay, creating a closed pipe system. Now within that closed pipe system also you can end up developing standing waves. Now because this blockage would change with inspiration and expiration, or say post coughing, often the type of wave, the exact composition of the compound wave that is being produced, okay, changes during inspiration, expiration, and then during coughing. So usually this wave is a combination of just very random lengths of bronchi vibrating at different frequencies and different amplitudes, which then changes during inspiration and expiration, therefore producing a non-musical sound. Okay, so these are the three physical mechanisms that actually produce sound that is heard and then amplified by our stethoscopes. And we'll see how this becomes relevant and how we use this for interpretation of type of pathology and localizing pathology while auscultating lungs. Or the wave at the bottom is a complex wave, and it is just consisting of actually a basal frequency and overtones of that frequency. Okay, and all of those waves are not phase shifted. That is, all of them are essentially sine waves. Okay, so it can very elegantly be shown to be a combination of those waves. So even with musical waves, you can have such a complex wave being produced. So imagine when waves, frequencies, and amplitudes vary very haphazardly, what kind of a sound will be produced? It'll be a very complex sound. So that is what we deal with and try to interpret. Okay, so now, as I've just said previously, any compound wave that lacks an abrupt change in amplitude and frequency is then termed musical, because it doesn't cause a displeasure or it doesn't cause discomfort to the listener. Okay, now on the left side, this is a normal periodic function, some kind of sine wave, either a sine or a cosine depending on where it is started. Okay, and this such waves, when they come together, when they are bunched together, and there is a large envelope wave that is heard by the listener, that is not displaceable, so it becomes a musical. Now this kind of a wave, see, with Fourier analysis, actually this wave also can be deconstructed into sine waves and cosine waves, but the human ear has got a range. It can only perceive frequencies between 20 and 20,000 hertz. Okay, so it doesn't have that infinite range of frequencies to deconstruct a sound with. So what ends up happening is that sometimes very low frequencies are required and very high frequencies are required, and then very disparate areas of the cochlea are moving very randomly at large amplitudes, almost simultaneously, without any clear pattern. So your auditory cortex, it finds it difficult to make sense of the sound. Okay, and as a result, that induces basically a subjective sense of displeasure. Okay, so this is what is a non-musical sound. Okay, now, like I said, a musical sound is typically produced when there is a single source vibrating at a relatively constant frequency and amplitude. So the standing waves produced from that can undergo positive interference and produce harmonics. Okay. Now the thing is, sound is produced, like I said, within the lung, and then as it is passed through the alveoli being small air spaces, spheres essentially, they tend to filter out the high frequency components of the wave. Okay, so this is because it is only the high frequency waves that are able to are reflected by the alveolar walls and then undergo negative interference. So they on average get filtered out, whereas the higher frequency waves are able to pass through the alveoli because their wavelengths are longer than the actual diameters of the alveoli involved. Okay, so actually, interestingly, what I've shown here is a device developed by acoustic scientists in order to act as a mechanical high pass filter. Okay, to remove high frequency sounds, and you can see it is very analogous to the alveoli in the human lung. Okay, so I hope this is clear, and the intuition behind the physics is clear. Okay, I will not be going into the math behind it at present, but at the end of the series, I will be adding in some additional videos on how the principle of conservation of energy is used to derive the Bernoulli equation, and the various modifications to that we use in hemodynamics. So I'll be discussing the physics behind that. Okay, however, I would suggest you go into it in detail only once you get a good intuitive understanding of what we are dealing with practically. Now, basically, when you auscultate, what you're looking for is two things. Where is the pathology, which is relatively easy to understand, because wherever you are auscultating, it is presumed that the site of origin of the sound is closest to where it is best. Okay, so that's fine. The localization is quite easy, and essentially, we have specific areas over the chest wall that are auscultated. So those areas, as most of you will already know, are on either side: infraclavicular, supraclavicular, clavicular, then the mammary on either side, axillary on either side, infraaxillary on either side, then the suprascapular on either side, interscapular and infrascapular on either side. Okay, so naturally the supraclavicular and the clavicular areas subserve the uppermost portions of the lung, so the superior lobes. Okay, similarly infraclavicular also. Okay, whereas the mammary areas on the right side subserve the middle lobe, and on the left side that subserves the lingula. Okay, and the rest of it is actually all the suprascapular also is upper lobe, but the rest of it, that is the interscapular, infrascapular and axillary, infraaxillary, are all inferior lobes of the lung. Okay, now the axillary on the right side can be affected by middle lobe pathology. Okay, subsequent investigations will actually make the localization of the pathology very clear, so I don't want to spend too much time thinking about that. Okay, however, what you auscultate and how you interpret it, what type of pathology, is something, it adds a layer of understanding of the pathology that often even imaging is not able to add. Okay, because imaging can be somewhere in between. Is it a GGO, is it consolidation? Okay, is it GGO with consolidation, is it a mass, is it a consolidation? So the physical properties, the acoustic properties of the pathology add another layer, a dimension to your understanding of the pathology. Okay, fine. Now, basically, when you auscultate the lungs, pulmonary sounds can be divided into two types. Okay, those sounds that are heard when the patient is breathing normally in and out. Okay, so those are known as the normal lung sounds. Okay, and sometimes when a person has pathology, there are some sounds that are heard during normal respiration that are unexpected, that are normally not there. So those are called added sounds. And as we've already seen, added sounds can be musical. That is, there are no sharp sudden changes in the amplitude and frequency of the individual waves that form a part of the complex wave that you're hearing. Or they could be non-musical, as in there are sharp changes in the amplitude and frequency, producing not as pleasurable experience listening to the sounds. Okay, so the normal lung sounds are the tracheal sound that is heard when you put the stent directly over the trachea. The normal vesicular breath sounds, that is when you put it anywhere on the chest except for the right interscapular region. Now, bronchial breath sounds are heard normally on the right side interscapular region. So that is why they are called normal breath sounds. But usually when you hear a bronchial breath sound, it is related to pathology. Okay. Now, musical added sounds include stridor, wheeze, and rhonchi. And non-musical added sounds are the fine crackles, coarse crackles, and pleural drops. Okay. There is another sound called the squawk, which is a mixed sound. It has a musical component and a non-musical component. And so basically, where are the normal breath sounds produced from, normal lung sounds produced from? So there are three normal lung sounds. The normal tracheal sound, so that is obviously produced from the larynx. Okay, from the larynx, it dissipates in all directions, but because of the anatomy of the respiratory tract, a large portion of that sound is conducted into the air within the lung. Okay, now if you put a stent directly over it, what will you find? You will find that there is some sound being produced by the turbulence of flow of air through your vocal cords, because they're right next to each other. So produces a variable stenosis at that level, and that turbulence is what produces the sound. So naturally, because it is not a fixed stenosis, okay, the sound will have a wide range of energies, and will have high pitch components or high frequency components and low frequency components. Okay, so that is the normal tracheal sound. Now, the normal lung sound or the vesicular breath sounds that you hear, they are due to, again, the turbulence of air that the air experiences in proximal airways, but the sound then goes through the lung parenchyma because it is auscultated at the chest wall. So it passes through the lung parenchyma, which is obviously primarily constituted by alveoli, and the high frequency parts of it are filtered out. So the lung parenchyma functions as a high pass filter, okay, high frequency filter. So as a result of that, you hear only the low frequency components of the sound. Okay. Now, the site of origin of the sound varies whether depending on whether it is during inspiration or expiration, because the lumen of the bronchial tract changes during inspiration and expiration. Now, why is that? So that is something that we need to actually understand in detail. It's very relevant to subsequent discussions as well. So during inspiration, the chest expands. Okay, why does it expand? Because the diaphragm moves down. We've discussed this previously. If you're inspiring with force, intercostal muscles also contract, lifting the ribs upwards, right, and laterally. So that is like the handle of a bucket, that kind of movement. So like the handle of a bucket, the ribs are moved upwards and laterally like this. Okay, increasing the right to left dimensions of the chest wall. And if it is a forced inspiration, the other accessory muscles also lift. The scalenes and the sternocleidomastoid will also lift the first rib. Okay, again like a bucket handle upwards. Okay, so the first rib is actually obliquely placed like this here underneath the clavicle. Okay, and it is lifted upwards. Okay, so another muscle that is involved is the quadratus lumborum, that basically stabilizes the 12th rib. But these are the muscles that are activated. So when that happens, the chest wall moves a little bit outwards in all directions. Okay, as a result, the potential space between the parietal pleura and the visceral pleura increases, and that causes the pressure inside to become negative. Now, if the lung compliance is normal, this negative pressure will result in the lung expanding, and expansion again causes increase in the volume within the alveoli, decreasing the pressure within the alveoli, creating a gradient between the alveoli and the outward opening of the respiratory tract. Okay, so that causes air to move in. Now, see, as per the law of conservation of energy, energy really cannot be created or destroyed. So we're not doing any nuclear fission or fusion here, so that holds. So any system has got potential energy, kinetic energy. So any work done on a system is equal to the change in potential energy and the change in kinetic energy. Okay, that is basically what the Bernoulli equation is derived based on. Now, when the air within the airway starts to move, its potential energy gets converted into kinetic energy. So as a result, the lateral pressure that it is applying on the lumen of the airway within which it is housed, okay, so that decreases. Now, during inspiration, this is not much of an issue because there is negative pressure outside. There's negative pressure outside, so that essentially acts like a stent. It keeps the airways open. Okay, so now where does turbulence occur? So turbulence is related to the rate of flow, and rate of flow by our continuity equation, that is area times speed, is a constant. Okay, so wherever the area, the cross-sectional area of the airways is the least, that is where the flow will be maximum. That is where the probability of turbulent flow occurring will be maximum. So during inspiration, it is more distal airways that have that experience turbulent flow. So this includes the lobar and segmental bronchi, and during expiration it is the reverse that happens. So during expiration, all of the muscles of respiration actually relax. So once they relax, the chest starts to compress or contract back again. Okay, as a result, the negative intrapleural pressure goes back to zero. As a result, lungs housed inside also go back to a lower volume, so increasing the pressure inside the alveolar space, and that results in a positive pressure inside the alveoli in relation to atmospheric pressure, causing a movement of air back out of the lungs. Now again, air is moving, so the lateral pressure applied by the air on the bronchial walls decreases, but now there is positive pressure outside. So if this is the airway, there is positive pressure compressing the airway, and the lateral wall pressure that the air within the airway was providing has decreased. So during expiration, what ends up happening is that the airways tend to collapse. They collapse on themselves, and when they collapse, their internal diameter, effective internal diameter, decreases, and that increases the resistance to flow. So this is a concept again that we'll come to when we discuss PFTs, and this is a very important concept. But basically what that implies for now is that turbulent flow that occurs during normal respiration, during inspiration occurs in more distal airways, okay, because those are the ones with the smaller diameters, and it occurs in more proximal airways during expiration, because expiration causes even the more proximal airways to become narrow. Now, okay, so now what is bronchial breath sound? So bronchial breath sound is essentially a sound that is heard when the normal turbulent flow that is occurring within the proximal airways and the high frequency components of the sound that are produced thereof are conducted to the diaphragm of the chest that has been kept on the chest wall. So why would this happen? It would happen either because wherever the sound is being produced, that is very close to the chest wall. So this happens in the right interscapular region because the right inferior bronchus, secondary bronchus, is very close to the chest wall. So there's little lung parenchyma separates it from the chest wall. So because that is the case, what ends up happening is that turbulent flow that occurs during it, the turbulent flow that occurs within it during inspiration actually can get conducted. The high frequency components can get conducted to the chest wall. Okay, so you hear bronchial breath sounds in the right interscapular area. Okay, this is something that you routinely hear. Now, if the lung parenchyma between the site of origin of those that high frequency plus low frequency sound and the depth has been opacified by some process. Okay, so this kind of opacification, as we've discussed previously, is called consolidation. Okay, so that could be any type of material, okay, as we will discuss in our discussion on chronic focal consolidation. But the acoustic properties of the airway are lost regardless, okay, of the alveoli are lost regardless. So that is why the hearing of bronchial breath sounds at any point, at any location within the chest cavity, other than for the right interscapular region, indicates that there is an underlying consolidation. But see, this has high positive predictive value. If you don't hear it, it doesn't really mean that there is no consolidation there. Because if there is some area of consolidation, but there is also some normal area of lung overlying it, or the area of consolidation is just peribronchial, the rest of the lung will filter the high frequency components out, okay, and you will not hear bronchial breath. So again, this has a high positive predictive value. If present, it means something. If not present, doesn't really mean anything. So now there is another thing that we need to discuss while differentiating vesicular breath sounds from bronchial breath sounds. The duration of expiration versus inspiration is something that is often quoted. So let's understand why there is a difference. So see, when you are hearing vesicular breath sounds, you must understand that the alveoli are functioning as a high pass filter and they're removing the high frequency components of the sound. Okay, so as I said earlier, during expiration, particularly during end expiration, there's a lot of positive pressure outside of the bronchi. Okay, there's positive pressure compressing the bronchi from outside, and the air within the bronchi is moving. Because it is moving, its potential energy is getting converted into kinetic energy, and that potential energy is actually what was keeping the airway patent by applying lateral pressure on the wall. So as a result, what ends up happening is that the airway essentially collapses in on itself, and this increases the resistance to flow. So when it collapses in on itself, this also results in a higher amount of turbulence occurring, and turbulence equals a higher component of the energy that is being converted into sound being converted into high frequencies. If you see the component, the amount of sound that is being produced throughout expiration, how much of it is high frequency. During the initial and middle phases of expiration, most of it is not high frequency, okay, but during the end of expiration, most of it is high frequency. So essentially what ends up happening is that the latter one third of expiration, the high frequency sounds that are being produced are completely filtered out by the alveoli overlying the site of production. Okay, so the expiratory component becomes short. Okay, now during inspiration this issue is not there. During inspiration there is negative pressure outside the airways, and because there is negative pressure outside, turbulence doesn't really occur as much in the distal airways. So as a result, most of the time during inspiration there is very little turbulent flow, therefore very little part of inspiration is represented by a high frequency sound being produced. So very little of most of the inspiratory duration, most of inspiration can actually be heard with the stethoscope quite clearly. Okay, so that is why there is a disparity in the duration of audible expiration and inspiration. There's a gap between inspiration and expiration when you are auscultating normal vesicular breath sounds. Now with bronchial breath sounds, this issue is not there. There is no high pass filter that has been nullified by the pathology. So both components are equal in duration. I hope that is clear. It's a very important concept to understand in terms of the normal auscultation of the lung. Okay, so if you use actual acoustic devices or what is used in acoustic sciences to document this, what you'll realize is normal tracheal breath sounds, the range of frequencies that are there is from 100 hertz to 5000 hertz within audible range. Now in normal lung sounds, the 1000 to 5000 hertz component of that is filtered out. Okay, and in bronchial lung sounds that doesn't happen. That component is allowed to pass. The intensity of sound, now because we are auscultating the trachea right over the trachea, when you're auscultating a normal tracheal sound, the intensity is maximum at the higher frequency. So it's around the median, the highest amplitude of the sound. Okay, the loudness of the sound is maximum at around 800 hertz. And actually most of the energy is concentrated between around 100 to 1500 hertz. So that is how the normal tracheal sound is. Now with normal lung sound, because the high frequency components have all been removed, most of the energy is actually in the lower frequencies, so around 100 to 200 hertz. Okay, that is why often it is very faint to hear. And with bronchial breath sounds, because we are auscultating it away from the source of origin, usually the maximum energy is held between 200 to 800 hertz. So if you were to do a formal assessment of the amplitude, intensity and frequency of sound, of the complex sound being produced during aspiration, this is what you would find. But this is more of a theoretical consideration. In actuality we don't do this. Okay, again, just to reiterate, sounds can be of two types. Added sounds can be of two types: musical sounds and non-musical sounds. And we've discussed abrupt changes in frequency and amplitude of sound are what make it non-musical. Okay, or make it difficult to listen to, basically. Okay, and we've discussed that musical sounds are typically produced by a single source vibrating at a relatively constant frequency and amplitude. Okay, now let's see how musical sounds would then therefore be pre-produced. Now one, we've discussed that some fixed stenosis can produce a turbulent flow from just one side. So that can produce a relatively pure sound which can then be musical. Okay. The second thing is you can get musical sounds from open airways. Okay, vibrating at a relatively constant range of frequencies. Because see, on the right side of the lung, on the left side of the lung, or within a given area of the lung, there is a group of airways of a certain size. Then distal to that, there is a group of airways of a certain size. Then there is a group of airways of another size. So all of those airways of a certain size and a certain wall tension would vibrate at the same frequency. So there will be discrete, clumps of frequencies that are vibrating at the same time. This is actually what results in the production of, so if it is more proximal, it results in the production of what we call rhonchi, and if it is arising from more distal airway, we call that wheeze. So these are the three mechanisms by which musical sounds are produced. So let's just compare the three musical sounds. So stridor happens because of a relatively fixed obstruction that is occurring in the usually at the level of the glottis, that is at the level of the larynx. Now, because the level amount of obstruction at the larynx the can vary, the frequency of the sound is very varied. And the other thing is, because there is so much, it is all of the air that comes in and out of the lung passes through that one small narrow area, the peak velocities that are reached, and therefore the frequency of sound that contains the maximum energy is very high. So usually the fundamental frequency, that is the lowest frequency of sound that forms part of this musical sound, is usually higher than 500 hertz when measured quantitatively. Now, if there's an obstruction in the level of the larynx, it happens when you inspire. Okay, so during inspiration, the suction pressure is produced within the larynx, and that pulls in the obstruction, that worsens the obstruction. It is better heard during inspiration, and during expiration, actually, there is something pushing out the obstruction. Okay, so as a result, essentially, it stents the obstruction and it gets partially relieved. So, usually, you hear stridor better during inspiration than expiration, but obviously, stridor is very severe, it will occur during both inspiration and expiration. Okay, now, what about wheezing? So wheezing happens because of bronchospasm in the second to seventh generation of divisions. Okay, so when bronchospasm happens, what happens is that the smooth muscle contracts and the bronchi essentially become rigid. Okay, because they become rigid, they can now vibrate at a frequency that is audible to the human ear, and that frequency happens to be 100 to 5000 hertz. The lowest frequency of sound that is produced here is usually less than 500 hertz, and that helps you differentiate it from stridor. So clinically, actually, stridor will be a very high pitched but relatively pure sound. Okay, whereas wheezing is a low pitched, relatively pure sound. Now, wheezing can be polyphonic or it could be monophonic, as in multiple different frequency of wheezes can be heard simultaneously, which is then called polyphonic, and it can be monophonic also. So monophonic wheezing can also be due to an obstruction little bit more distal in the airway. Okay, so that is something that we need to keep in mind. Now again, because the tensing up of the airways and the flow through the airways is maximum during end expiration, and if there is no negative pressure outside the airways to prevent their collapse during end expiration, wheezing is best heard during end expiration. So it is more during expiration than inspiration, whereas as we've just discussed, stridor is the reverse, it is more during inspiration than expiration. A rhoncus is essentially just a wheeze, but it is produced in a very proximal airway. So because it is produced in a proximal airway, the more proximal the airway, the larger its diameter. So the frequency of sound that is produced is actually lower. So usually it's around 150 hertz, 100 to 200 hertz. And therefore the fundamental frequency naturally will be much below 500 hertz. Importantly, why would such a proximal airway start vibrating? There is a cartilage skeleton, it doesn't have that much smooth muscle, as we've discussed in the previous talk. So when does that happen? So that happens when there is a fluid film that has formed within that airway, increasing the surface tension there because there is an air fluid interface there. Okay, so that is when it happens. So a rhoncus basically indicates that there is some fluid that is there within a relatively proximal airway. Okay, and wheezing indicates contraction or increased tangential rigidity of the second to seventh generation of airways within the lung. So the thing is that with fine crackles and coarse crackles, what happens is, in fine crackles we have during expiration or during the end parts of expiration, because of the positive pressure being applied out from outside, and because there is some architectural distortion, say due to interstitial fibrosis, some of the airways collapse. Okay, now which airway, what lumen size or diameter of airway, where, all of that is very variable. Okay, it depends on where the fibrosis has occurred, the primary areas of fibrosis and things like that. But during inspiration, again, because of the positive pressure in the outside of the airways suddenly open up. That, depending on which airway was had collapsed during the previous expiration, that it will be the frequency and the amplitude of that of the waves that constitute the complex wave that is heard. So these will be very random, and the amplitudes will also be very random. The frequencies will be random, as a result producing a very non-musical sound. Now, with coarse crackles, the mechanism is slightly different, although it is similar. So with coarse crackles, what is believed presently is that because there are a lot of secretions within the airway, bubbles within those secretions block airways and end up producing closed pipes of varying length within the airspace. Okay, so during expiration and during inspiration, what ends up happening is during expiration the bubbles move more towards the outside, and during inspiration they move more distally. Okay, so when they move more distally, they end up blocking the distal airways. So when they block the distal airways, it ends up producing a closed pipe system, and that can then produce a particular frequency. But see, what size of bubble, where it get, in which airway is it getting stuck, okay, where is it getting stuck in that airway, will result in a very random distribution of airway lengths and airway diameters that are producing this sound. So the sound that then gets produced is actually a very random collection of frequencies and amplitude, often with rapid abrupt changes. So that is why it is non-musical. Okay, so I presume that is you've understood the difference between the musical sounds and the non-musical added sounds, and I hope the physics is clear. Is the intuition behind it is clear. Now, when it comes to fine crackles, because fine crackles are due to changes in the architecture of the lung in that particular area because of interstitial fibrosis, if the vector of gravity being applied in that particular area changes, that is, the patient changes position, patient lies down, okay, often what happens is some of the airways that were collapsing during expiration in upright position no longer collapse, as you can see in this diagram. So here, when the patient is upright during your expiration, some of the distal airways collapse, but when the patient is lying down, though, that airway doesn't collapse. Okay, so during the subsequent inspiration, these airways will open up. Okay, they open up, but here there is nothing to open up in the diagram at the bottom. So as a result, here on top you will end up getting crackles, and when the patient lies down, those same fine crackles are absent. And this is actually a very important feature of fine crackles. Okay, so it's sometimes difficult to differentiate between fine crackles and coarse crackles. One definite way of differentiating fine crackles from coarse crackles is just change the position of the patient. Fine crackles will change in their, see, they may not disappear, but they will change in the location and the type of fine crackles that you hear. Similarly, because it is bubbles that are producing the coarse crackles, okay, if you ask the patient to cough, okay, post cuffing, those coarse crackles will again change. They may completely disappear, they may change in their character, the exact type of sound that is being produced, but they change. Okay, so these are two maneuvers that can help you to differentiate between fine and coarse crackles. Okay, now there is one last non-musical sound that we need to talk about, that is a pleural rub. So a pleural rub is produced when inflamed visceral pleura and parietal pleura rub against each other. Because they are inflamed, the surfaces are no longer smooth, and because they are no longer smooth, and also the amount of fluid that is being secreted is not sufficient, so the coefficient of friction between these surfaces increases, so they get stuck. There is inertia, and then when that energy is released, suddenly the two surfaces vibrate and they produce a random combination of frequencies and amplitudes, which is what we call a pleural rub. So unlike the other sounds, however, these sounds will be best heard where the site where they're being produced, because they are actually being produced right next to the surface of the chest. So this is a comparison between the three types of non-musical sounds. So as we've seen, fine and coarse crackles are differentiated based on the frequency of sound that is being produced. Now, and the duration of sound that is being produced, with the fine crackles being less than around 5 milliseconds, and coarse crackles usually lasting around 15 milliseconds, 10 to 15 milliseconds. Now, we've discussed the mechanisms. The fine crackles are caused by opening up of airways that had collapsed during the previous expiration. Okay, whereas coarse crackles are due to bubbles moving out and then in during expiration and inspiration respectively, and as a result closing of airways producing closed pipes that then vibrate at various frequencies because of their differing lengths and diameters. Now naturally fine crackles would be best heard when the airways open up, so that will be during mid to late inspiration. And coarse crackles will actually happen when they will happen during expiration as the air bubbles move, okay, and get stuck. They also happen during early inspiration, so that is another thing that can differentiate between the two, okay. And fine crackles typically are heard in basal locations, but this is because most fibrotic lung disease has a tendency to affect the lower lobes. We'll discuss this when we discuss ILDs, but they can occur in other locations also, particularly if you have, say, fibrotic hypersensitivity pneumonitis or something, or sarcoidosis. They can happen in the upper lobes. Okay, now coarse crackles essentially can occur anywhere because mucus or fluid accumulation can occur anywhere. And as I discussed previously, fine crackles importantly show changes with posture of the patient, whereas coarse crackles change with coughing. Now, pleural rubs are heard best wherever they are being produced, and they are present during inspiration and expiration because essentially it has nothing to do with lumen size of any of the alveoli or the airways inside. Now, putting everything together, essentially the first thing to do when you are interested in examining the pulmonary the pulmonary system is look at the whether the trachea is shifted to one side or the other. Okay, if it is shifted to one side, opposite side, if there is stony dullness, that means on the opposite side of the tracheal shift there is fluid. Okay, and that's about it. Don't worry about it anymore. After that, auscultate. Okay, and be very diligent while auscultating. So compare on both sides simultaneously and go through each of the areas because auscultation will help you localize. And then we know that the what you hear is essentially two types of sounds: the normal breath sounds that a person can find that are produced within the airspace, and added sounds. Okay, and we've discussed the interpretations of each of these sounds, and using that interpretation you can attribute certain characteristics to a pathology and localize it using auscultation. Okay, so that brings us to the end of our discussion on pulmonary physical examination. As you can see, like any physical examination, it has a high positive predictive value. If present, it means something. If there are no findings, it actually doesn't really mean anything. Okay, in most circumstances. Now, the next video will be on cardiac physical examination, excluding auscultation or murmurs. And subsequent to that, we'll discuss pulmonary functional test analysis, and finally, we'll move over to interpretation of 2D echocardiograms.